Good morning. Thank you for letting us present our work. These are our disclosures. So the opioid epidemic is one of the biggest health concerns we have currently. And many of us have seen graphs very similar to this, where from 2000 to 2015, the rates of opioid-related deaths have continued to increase. Despite increased attention on this issue over the past few years, opioid-related deaths have continued to increase, at least through the last quarter of 2017, with the most recent estimates being of roughly 175 deaths per day. Prescription opioids are very relevant to this. In 2012, there were 260 million prescriptions filled, which is essentially one bottle for every adult in the US. Excuse me. And importantly, 40% of opioid-related deaths involved a prescription that was legally prescribed to that patient or their family member. Now, why is this important to surgeons? Well, we are uniquely involved in this problem. 70% of perioperative opioid prescriptions are prescribed by surgeons, and one study out of California demonstrated that 1 out of every 10 opioid-related deaths, that prescription came from a surgeon. We've also seen negative associations between opioid use and our patients. So previous work out of the University of Michigan looked at patients who had chronic preoperative opioid use and saw that they had increased spending in their hospitalization, increased rates of complication, and increased rates of hospitalization. However, the group that's garnered the most attention in the surgical population is those with new persistent opioid use, or patients who were opioid naive preoperative and then developed new persistent use postoperatively. The M-Open, which is a large group at University of Michigan, which is focused on studying the opioid epidemic, demonstrated that patients undergoing elective major and minor operations had a risk of 6% in terms of developing new persistent use. And importantly, they included bariatric surgery patients in that major operation group and saw that in that cohort, 7.8% developed new persistent opioid use. While there's been a lot of focus on this group, no one has really looked at the link between new persistent opioid use and surgical outcomes. And we therefore sought to determine the relationship between new persistent opioid use and both physiologic and psychologic outcomes of bariatric surgery. To do this, we utilized the Michigan Bariatric Surgery Collaborative, which is a quality improvement collaborative in the state of Michigan and includes roughly 40 hospitals and has clinical data on approximately 95% of the patients undergoing bariatric surgery in the state. We identified patients 18 years and older undergoing primary bariatric surgery between June of 2006 and December of 2016 and excluded patients that had preoperative opioid use. Based on self-reported surveys, both baseline and at 1 year, we identified roughly 22,000 patients who underwent primary bariatric surgery and were opioid naive pre-op. We stratified those patients into new persistent opioid use or no opioid use. And new persistent opioid use were defined as patients who on their preoperative baseline survey said they did not have an opioid prescription, and also at their 1 year follow-up then reported having a prescribed opioid. We looked at risk-adjusted outcomes, including weight loss, psychologic outcomes, including body image, psychological well-being, and depression, and overall satisfaction with their bariatric surgery at 1 year. We saw that for new persistent opioid users, we saw that in our cohort that 6.3% of opioid naive patients developed new persistent use, and that these patients tended to be older, non-white, had more comorbidities, and were more likely to undergo Roux-en-Y gastric bypass and suffer a postoperative complication. They also were more likely to carry a diagnosis of depression or bipolar disorder and be single or not living with a significant other. We first looked at percent excess body weight loss between these two groups at 1 year and saw a statistically significant difference with new persistent opioid users losing 50% or 57% of their excess body weight compared to 60% in the non-opioid use group. When we looked at psychologic outcomes, we saw that new persistent opioid users had poor outcomes overall on all three of our measures. So for psychological well-being, there was no statistically significant difference at baseline scores. However, at 1 year, new persistent users scored lower on psychological well-being, and a similar trend was seen with body image. For depression, where lower scores are worse as opposed to our other measures, we did see that based on our univariate analysis, it's not surprising that there was a statistically significant difference at baseline. But when we looked at the 1 year, that gap grew, and the change was significantly less for new persistent users, so they improved or had improvement in their depression symptoms, much less than the non-use group. Satisfaction was ranked based on a Likert scale asking Essentially, how satisfied were you with your bariatric surgery experience? And we saw that new persistent opioid users had statistically less satisfaction. Overall, in our cohort, 6.3% of opioid-naive patients developed new persistent opioid use within 1 year, and that was associated with decreased weight loss, poor psychological outcomes, and decreased satisfaction overall. And so I think the most important thing to take away from this is that this adds to the growing literature, but also takes into account that new persistent opioid use is a fixable problem, and there's really kind of 3 areas we should focus on. The first is on postoperative pain management strategies and our prescribing habits. There have been recent guidelines that have looked at general surgery prescribing habits and suggested what those doses should be. However, given that many risk factors we know to be linked with new persistent use are very prevalent in the bariatric surgery population, we may need specific population guidelines that help us navigate this a bit better. And also, there's been some work looking at intraoperative and immediately postoperative non-opioid pain management strategies, but this should also be continued to be evaluated postoperatively after discharge. And in Michigan, at least, this adds to current infrastructure and legislature that's been enacted. So recently, Michigan passed a law where we as physicians are only able to prescribe 7 days of pain medications for acute pain. And in July, one of our largest payers will be enacting enhanced surgical fees for surgeries not associated with a postoperative opioid prescription, with bariatric surgery being one of those surgeries that will be included in this. Finally, a lot of studies have looked at risk factors for new persistent opioid use, but we need to do a better job in developing postoperative surveillance programs, both for early recognition of those at risk of new persistent use and having atypical use patterns, but also thinking of that as a flag for patients that may be at risk of poor outcomes following bariatric surgery. And a lot of this will be built on our shoulders in appropriately counseling patients on the risk of opioid use, helping to motivate them to seek alternative pain strategies after discharge, and also setting appropriate expectations preoperatively, not only for the pain that they can expect, but also what their pain management strategies will be following surgery. Thank you. I'll be happy to take any questions.